Chyba zadziałało. Okej. Okay, Stefanos. We are there, I think. I guess. Yes. Yes, we are there. We are live now. But I think
you're going to be telling me about how many people are there.
okay. Yes, we are streaming now. There are like 0 people now. So I think we can wait for 1 minute. And I think I'm gonna see on my telephone. If it's working.
Is anyone here?
Not yet, I think.
Oh, there are 8 people.
It's working. There are people?
Yes, or at least that's what I'm seeing.
You have to.
I see that 8 people are watching. Oh, there are 8 people.
It's working. There are people?
Yes.
Okay.
Or at least that's what I'm seeing.
Okay, I'm just trying to see if we are hearable. If you hear us.
And they will have to go.
If you hear us
with
put
us.
your hands up in the air.
So we will probably wait for
Yeah.
some more people to come in.
Yes. Hey everybody, we see some people. I see 2. I cannot see how many people are there now.
So I see Elena, who probably is Helena Nix from.
Yes, probably Helena from Austria. Yeah.
From Austria and the school, yeah. I see my attending from PRM in Vula, and I see an orthopedic friend, another resident from Vula. So we'll probably wait a little bit more for some people to come in.
Yes, I will put that on Instagram now, I think. Yeah. So just like to remind the people.
So I'm seeing that even more people could be in, but we are not seeing them on the chat. YouTube is probably a starting point. I'm guessing that we would rather have a more interesting medium of communication next time, like somewhere where people can actually open their mics and give actual input.
Yeah, probably. But you know, I was thinking about more professional way to stream, but everything was not for free. And as we say in Polish, free price is a decent price. So, you know.
So yeah, maybe, I don't know, we could use the actual meetings platform.
Yeah. In the future, probably we will be make it more open.
Let's see if people like it, if it disseminates, if they join, because if it's like 5 to 8 to 10 people, then we can probably keep going through this way.
Yeah.
We are hoping to not go deep into the night and keep this nice and easy, like an hour or so, along with the input from everyone here.
Yes. We would like to encourage you to ask us questions or like your ideas also through the stream, and afterwards we'd really appreciate your feedback about the stream, but still we want to have fun from it, so let's see how it rolls. I think it's like 9:07 in Poland. In Greece, what time is it now?
10:07.
10:07.
1 hour later than you, not that much,
Yeah.
but close to happy sleeping time. So
Yes. My children are asleep now, so a little bit of clonazepam.
I'm also gonna put a YouTube link that we are live.
Yes. Put it. I haven't made a link to you. I haven't made a how it's told. Oznaczyć.
Okay.
I haven't tagged you. I haven't tagged you on a.
You don't need to tag me. People just they'll have mine.
Yeah. Okay, I think we can go now. This is the time. So
Yes.
I will start by introducing myself for your audience from Greece. And I'm Marcin Piwnik from Poland. I'm a PRM specialist and a US PRM fellow. And I passed my exam in 2022, and I'm just a PRM specialist that are very into orthopedics, rehabilitation, neuropathic pain, neuropathic injuries, a lot of ultrasound and ultrasound guided interventions in PRM, and I also really like training, mainly strength training and kettlebell training. This is like my thing. Personally, I'm also a father of two young boys, and that's all about me. And you, I think.
So I am a rehabilitation doctor, PRM. We call it also physiatrists.
Yeah, physiatrist.
And I'm finished rather my residency a few days ago. I'll be taking the national exam in September, and I have also already passed the European board examination. So I'll be probably going into pain, more or less, and I feel like maybe trying in the future to go more into the interventional field and working my way to more of a trans-European collaboration with colleagues. Let's see how that works out.
We can also say how we met. We met at the first was the robotic rehabilitation school in 2017 or 19? 19.
It was 19, I think,
19,
yes.
yeah. Porto Potenza in Italy. And then we met again at pain rehabilitation last year in September in Piacenza. This was also a summer school from ESPRM. and our friendship burned again. And we met also last it was 2 weeks ago in Slovenia, in Ljubljana, for the Congress. And yeah,
And we are hoping to meet again in
yes,
Krakow or in general in Poland in
Poland.
June, but it is on the works.
It's on the works. Yeah, so I think we share the same passion we share the same passion for rehabilitation, for the pain, for expanding our knowledge and for expanding our possibilities to help the patients, and that's why we talk a lot now, I think.
And actually, the thought behind this whole stream thing was to actually start a journal club, like something that we could talk between doctors of different specialties or the same specialty, like neurology, orthopedics, PRM, physical therapy, maybe hand therapy, maybe anyone who is interested in stuff like that, because we don't actually have a platform to speak with people from different countries and just have an informal watching webinars. You do not get to interact. Like, we had a thought that maybe we could just spark some conversations and have people write in the comments, or later, if we do more of an interactive stream where people can actually say something on their mic and have an actual journal club in the way we used to have in big clinics, where we would get 20, 30, 50 people, and we would between us have nice conversations. We picked the issue of neuroplasticity and nerve injuries for today, peripheral nerve injuries, and it was a very nice but very difficult topic, I would say.
Yes.
And I think that we should see the article that we have prepared and go from there.
Yes. So you will start about the etiology and the pathophysiology, and I will try to wrap it up with the management, new kind of looking at the management of peripheral nerve injuries now, with the neuroplasticity window. So I think you should share now the...
Yeah, I will share my screen now. And the thing is that I also had kind of a problem. I cannot see who is in the room.
Who's in the room?
There is no way for me to see that up to now.
Yes, I
keep seeing like one or two people.
I see the chat now. I see if nobody asked any questions. So I think that
we don't expect questions, but it would be nice if we could maybe see.
I will show you later the chat. Okay.
Okay.
So now
we got people going on.
Yeah, we got like 18 people, 19 people.
Okay. Also, if anyone knows me from these people, you can also contact me. I'll have my phone open so I can see here that something's going on, so I don't go blindly into the night and step on whoever knows what. So this is our first journal club.
Yes.
And what we are going to be doing during this is a very early presentation. I don't expect anyone to like the actual presentation, but it's a means for us to just know and talk about the same thing. We're going to pick an article, and afterwards we're going to talk about it, offer some info that we gathered on rather interesting stuff inside this article or other articles, maybe catch up with each other, stir up conversation, maybe get more people involved as we go. And mainly keep it informal and just have a 20, 30, 40-minute talk each time with your input, of course. We'd like to keep our part like for 10 minutes and less. So today, peripheral nerve injuries, pain, and neuroplasticity. It was in the Journal of Hand Therapy in 2018. It was a scientific and clinical article, not an actual study, but a review article. So Let me see if I will probably do it this way. Okay, so let's discuss a little bit about the actual peripheral nerve injuries. We have people that have their nerves injured. They usually report two major symptoms. The one is the motor deficit or sensory motor deficit because they cannot move, they cannot touch, they cannot produce the movement, and they also cannot feel, they cannot touch, they cannot feel the touch actually. The second one is the neuropathic pain, and that is mainly allodynia, which means that you have pain where you should not have pain, and hyperalgesia, where you have more pain than you should with a given sensory input. And you also have referred pain from places that are not within the part innervated but by the actual nerve that was injured. The problem is that many people that have had their nerve injured have not returned to work even 1.5 years after their surgery, where they did, if they did the surgery, if they needed one. And almost 60% are young people. So we have a lot of disability going on. And many times we see people addressing peripheral nerve injuries like a self-healing injury or a wait-and-see approach, or go ahead, move it, and it will just grow on its own. And it pains me to see it in clinical practice, but it is actually very common in Greece. Let's just have an overview of how we categorize it. So if you have a grade 1 injury, it's just the myelin sheath. You have an intact axon, it just has a conduction block, which means the nerve is not working. It's going to take some days, it's going to take some weeks, it's going to come back probably totally. Maybe it's going to be a little bit slow, but it's going to go all right. Then you have the grade 6, which is the last grade, the biggest thing you can have, which is a total resection of the nerve. So you have a laceration or a cut, and you have two parts of the nerve, and you have a gap in the middle. And then you have everything in between, which means that you have some damage into the axon, some damage into the endoneurium, some in the perineurium, and some in the epineurium. So different types of damages, including different types of soft tissues along with the axon and the myelin. So one, and it goes all downhill from there. We will refer to everything as a neuropraxia when the nerve doesn't function. Axonotmesis is when the axon is the problem, and neurotmesis is when the whole nerve is gone. And we need to also remember that when you injure your nerve, you could crush it, you could cut it, you could stretch it, you could rub it, you could compress it slowly, you could have thermal, cold, hot, you could have radiation, you could have chemical burns, you could have any type of injuries. And you should always, like as a clinician, be mindful of the nerve structure and its biomechanical properties. Like nerves can actually sustain a lot of load and undergo not a plastic compression, but a one that can go back to normal. So having that in mind, and the nerve sliding and gliding, also within each fascicle, you can have gliding within the nerve. You also have blood vessels, the vasa nervorum, within the nerve, which, if compressed enough, can lead to hypoxia and cell death, or it can lead to blood stagnating from not the arteries, from the veins, and that could also bring about a problem. So we have two different mechanisms that are presented also in the article. Like the one is the regular axon regeneration. We're going to talk about it, and it's basically it's regrowing the way it's supposed to regrow. But we also have collateral sprouting as a second type of regeneration. So if the end organ is denervated, so it lost its function, then we have to manage to get that function back. So the collateral sprouting means, I don't know if I think I have a picture for it. Okay, I didn't. So like you can have a nerve that tries to go through to a muscle and it doesn't, but other fibers go to that muscle. That fiber maybe will not regenerate all the way to touch back on the muscle, but the other nerve, the other nerve fibers may sprout and try to enlarge their motor unit, like they try to attract more muscle fibers, so the muscle fiber gets bigger, and which is what we see after a little bit. We also see those very big motor units which are not very distinct, but collateral sprouting is not uniform between fiber subtypes, so you can have different type of reinnervation for each fiber type. We have way more data for the central nervous system, like how that happens in the cortex, how that happens on subcortex, how it happens on the brainstem and down on the spinal cord, but very little data on peripheral, actual peripheral nerve fibers doing that. But also in humans, we are also thinking it could have a limited effect. However, the one that happens upstream of a peripheral nerve injury, so I injure my nerve, upstream, there are changes into the central nervous systems, which is part of the neuroplasticity that could offer functional recovery as opposed to a true anatomical repair, or they can go into maladaptive plasticity and produce pain or a lot more bad things. So just a little bit, and not to go very, very much away from stuff into the physiology, just because in my mind, I had a lot of trouble deciding what Wallerian degeneration was. So when you have a nerve and it is injured at some point, then the distal stump, the part that is away from the damage, breaks down its cytoskeleton through a de-differentiation of Schwann cells. So the Schwann cells that used to be just around the nerve producing the myelin, they undergo a transcriptomic change, and they change their phenotype now into a repair phenotype, and they secrete different type of molecules. They attract the macrophages, and they take on many responsibilities. Some of them, they become these elongated bonds of Wagner, which you can see, like, instead of being that thing that goes around the nerve like an insulator, they now build those bridges with which they guide the regrowing axon to creep up and touch on the right place, because the axon doesn't know where to go. So the Schwann cells actually differentiate into that repair state, and they guide, they secrete stuff, they produce the space and the environment for the axonal growth, while the proximal stump grows into a growth cone, which tries to creep up while the DRG neuron itself produces urges for the growth cone to go up front. So we have a lot of functions for the Schwann cells, and I will also have a lot of different articles that we found and we read during our research for the talk. But also, as the neurons grow, the motor neurons tend to, they of course grow in whatever way they want, but the motor neurons, if they touch something that had motor function before, they get strengthened. If they touch a sensory function as at the peripheral spot, they then say, maybe this is not good, and they undergo pruning, so that sprout will not grow anymore. So there is a preferential motor reinnervation where the motor fibers basically decide on a 65 or to 70% rate where they will and where they will not go, which is one point that we will talk about later with stimulation. So on the periphery, we have on the one here down, I hope you can see my pointer, we have an injured peripheral nerve, and we are undergoing neuroplastic changes on the nerve, on the periphery, due to the Schwann cell differentiation, due to maybe having some collateral sprouting, which would happen also up here in the DRG, but we also have ectopic discharges and neurotrophic deprivation and hyperexcitable stumps. So we have also stuff going on that we didn't want to have there. So that's a part of the neuropathic pain. Upwards, again, we have hyperexcitability, both on the dorsal horns, where we have sensory neurons touching on the laminae of the dorsal horns to get the afferent scene, also with the motor neurons. So you have spinal cord reorganization, you have interplay between neurons changing just because you just now had the nerve injury. So it's not something that takes weeks or months. It starts basically right then and there.
Yes,
and then you have
it starts
upstream.
when the injury is. Sorry.
Yeah. So upstream, then you have the, reorganization up in the brainstem, up in the thalamus, up in subcortical areas, and up in the cortex. We have some mechanisms. Just we have unmasking of the actual silent projections that during development. There are many neuronal paths, mainly in the CNS and in the spinal cord, that did not actually produce any effect at all times. But then, if you have an injury, the cortex expands, the map gets bigger. More of these silent ones, because of the regenerative state, not only of the periphery and the Schwann cell, but also of the glia in the central nervous system, you have unmasking of those silent ones, which can take over a part. And also you can have sprouting of new axons, which will try to mimic what you had before. So you have plasticity going on upstream in the central nervous system just because you injured the nerve in the periphery. This is not for a central nervous lesion. But that is not very efficient. And it produces also a lot of stuff that we didn't want. We're going to talk about this later, and maybe this is the place where Marcin will touch on the therapeutic effect. So we won't go so much into the mechanism. It takes a lot of time, but we will mainly differentiate symptoms in terms of psychiatric, like negative and positive. Like we have the negative sensory motor and somatosensory deficits, like what you do not have that you had before, and into the positive sensory symptoms that you have what you did not have before, which is mainly pain and allodynia and hyperalgesia and paresthesias. So because of the reduced afferent input to the cortex, you have downstream and uphill differences in plasticity, which result in deficits. But then you have impaired modulation going down because of the differentiation into the CNS. So you have mainly spinal and all the way through the brain changes that result in pain, which could be said that starts from the ectopic firing because of the sodium channel accumulation in the stump. So you have ectopic impulses, as we said. We have the neuroinflammatory state of the DRG, the dorsal root ganglion, which is actually the cell body that goes through the peripheral. You have microglial activation. You have the reorganization of the spinal horns. You have an off-the-reins thing, like where you have excitatory drive, it increases and it's hyperexcitatory. Where you had excitatory to inhibitor, you don't get the inhibition. So you have excitatory and decreased inhibitory neurons. And then you have all the changes uphill and all the in the pain matrix areas. We won't go very much into the actual neuropathic pain because it's a whole cluster of things. So you have all these things just because you severed a nerve. This is a very nice article to go into. And before we go into the therapeutic approaches, I'll also link this one. I'm hoping we can go back, or you can ask for any of these because it's the first time and we don't know how it's going to go. Exercise could facilitate the regeneration, and this is an article for rats, and it's a very nice segue into me handing the baton to Marcin to talk about the therapeutic aspects and how we can foster everything we said about the physiology and try to help our patients. So you had rats where they cut the nerve, they cut a 5 millimeter stump, they turned it around and stitched it back on, and then they had rats do exercise or do whatever they want. And the rats that did the exercise had less pain and better regeneration, shown both in clinical lab translational tests and in actual histological regeneration. So with that, I pass it on to Marcin. I stop my presentation, and let's hear it from Marcin for the rest of the article. Marcin, the floor is yours.
Okay. Thank you for your presentation. Thank you. Like on a congress. So now I'm surely like to apologize because I didn't have time to prepare such great presentation, and just like really I didn't have time in last 2 weeks. I had a lot of other responsibilities, but I read through some articles and made some points for myself, and now I will try to like pack it up and give it to you now. Just like maybe next time I will have a better presentation, but that's not the point. We heard about a lot about the physiological stuff, about what changes in brain, and how can we translate it to our basic work, because sometimes it's very exciting to read about such thing as nerve sprouting, but how it addresses our clinical practice. And I like to keep it simple, just like if here this is the article that we read here, like maybe here I highlighted that certain pre-existing psychological states and personality traits can predispose to maladaptive neuroplasticity, that the peripheral nerve injury can prone to be worse in some patients, and we can assess the patient before like when they had a peripheral nerve injury. We can assess them if they are in risk of having worse outcome. So we can use such things as a central sensitization inventory. Sometimes I'm using it in my own practice, especially when I know that the patient will come back, and I have because I'm mainly working in my outpatient clinics, that he has a peripheral nerve injury, and I have to assess if their outcome will be worse or better. And also we can use such thing as pain catastrophizing scale. This is like the free one on PhysioTutors, and this has a very good reliability intra-rater, and this is like a tool that we can use to maybe predict the future, if the patient will recover better or worse. So sometimes we just like, okay, this is like psychological stuff, we don't have to go into this, but this is like very easy way. I also had one scale for low back pain. This is not like peripheral nerve injury, but it also was a calculator that could foretell the future. So another thing here is like because another thing is that in Poland I heard a lot of times that when the patient has a peripheral nerve injury, we should keep this limb in warm, because it encourages the nerves to grow. It makes the recovery easier and better. But this highlighted text told us that sometimes this is not about the warm that makes the nerve better, but mainly the patients with peripheral nerve injuries can have the cold hypersensitivity, and the worse the hypersensitivity to coldness, the worse outcomes. So maybe we should assess in our clinical examination the sensitivity of the patient to cold. This is like part of the quantitative sensory testing, which is very standardized type of testing in peripheral nerve injuries, but we can use some kind of cold tool. This is like a main tip term tool. I will show you what is a tip term. Maybe this is not the QST type of tool, but tip term is like this. Yes, this is like the cold one. This is like the not cold one. This is not a warm one because it's not electricized, but this is like the easiest and the cheapest tool to assess if the patient maybe has a hypersensitivity to cold. Also, if we have some cold drinks in our outpatient clinic, we can just tap our patient with our cold drink with a brick of ice. So this is another thing, and also we have to monitor the patient results. This is like the common knowledge. We have to monitor the results. We have to assess the range of motion. We have to assess the strength. But in the nerve injuries, we should assess the feelings of the patient. We should have some kind of algometer. We should have some kind of maybe better tool to assess the sensitivity to cold and warmth. So maybe a kind of a flask with a water on a certain kind of temperature, just to assess if the threshold for the cold sensitivity go up or down. And that's why also the patient will see, okay, now my threshold went up. So we can also work on their neuroplasticity in the central nervous system. And also another thing here is that because I was a trainer in the past, a CrossFit trainer, sometimes the patients didn't wanted to the clients didn't wanted to train to do some movements, like they were afraid of deadlifts or of squats because they were catastrophizing the movement or the pain that was associated with them, and I have to work around to make them bend the knee or bend the hip or bend the lower back, made another movement, or make it a game, or make it like a kind of a mobility exercise, just to imitate the deadlift or the squat, because this is like the basic movement. And also here we can work around to make the patient normalize their feelings. Like here, here are some proofs that the mirror therapy could make the affected hand, the peripheral, the injured hand, less sensitized for the pain. Just like watching the normal hand be touched could lower the pain threshold or the sensitivity threshold for the injured hand, and also the graded motor imagery. So graded motor imagery is a tool. Here it is. Yes, graded motor imagery. Very great, simple article on a Physiopedia where you show the patient some kind of movements that progressively will use the hand or the foot, where you show the people just like the progression and the regression for some movement. So also this is like maybe making the patient more comfortable with the idea of using this hand, because in the many cases they are afraid of using such limb or such area of body that are injured. They are prone to protect it from any kind of unnecessary using movement or touch or anything else. And the last one is for us. We talked about it before the stream. The sensor glove is just like it's just like putting the glove on your hand to amplify the sounds associated with touch. So you amplify in other words, the touch, the use of hand, it's not only associated just with touch or just with the grasp. It's just also associated with other kind of feelings, like the sound. When you like when I'm talking here, you hear my sound, but also I can touch the microphone and you can hear the cracks of my nails on the microphone, and this is amplifying the touching of the textures, could provide the audio tactile feedback for the patients, and this could normalize the feeling of the patients. Also, another technique is to use the local anesthetic. I think that this could be the EMLA cream, like the lidocaine with prolicaine, I think. Of course, the lidocaine cream that will make the skin the local sensory block of the skin, but not the region that are affected. So if you have the peripheral nerve injury, like here of the median nerve, you can put the cream on your forearm, which is not affected, just to lower the sensory affectations from this kind of region, to amplify the sensory remapping. Okay, remapping. Yes, this is the better word, just to remap. Yes, just like, I can, when you also adjusting the sound in your microphone, you can put the treble up, the bass down, or the other way. So you can put here this kind of region down, just to amplify the afferent signals from your hand, and that is also another fun technique to use. So in other words, you have to work around to make the patients use the affected region, the affected limb, the affected nerve, and the patient won't know if you make the Schwann cells work, or to make the unmask the other kind of nerves of afferentation roots to work, but they will feel the difference, and we can show them that there is a difference in their treatment, and that is the way to make our practice better. Okay, and that was my kind of presentation. Okay.
Yeah, I think it was a great thing, because what this article practically demonstrated is that it also talked before, like in 2 pages back, about electrostimulation, or how acupuncture, along with electric stimulation, caused a redifferentiation of the digits of the hand where they had kind of mixed together in the cortex. So
Yes.
they, what the fun thing and why we decided to do this was that you have physiological mechanisms on the one side, and then you have treatments working with those mechanisms on the other side. And since the actual evidence and the level of evidence for each one of these practices is very low, because our data come from translational science, from rabbits, from mice, from apes, from primates, from cats. Like pain and peripheral nerve injuries are mainly studied in these ways. So there is not enough work done to connect mechanism and actual treatment, and less work being done to actually have high level of evidence. So we have to try things for these patients. We don't have everything worked out. We don't have exact algorithms. We don't have exact science per se, because we have to think about mechanism and produce whatever we can to make those fibers work.
The
Like you have,
science,
yeah,
the science is one way, the one thing, but also in this study was the part that that told that the acupuncture of the distal part of the digits make the difference in the fMRI, so make the change the neuroplasticity of the cortex and reorganize the digital mapping of the mapping of the digits of the fingers. So
yes, and also the good thing to remember is that when you have an injured nerve, it is going to renervate probably in some way. We can talk about indications for surgery or anything, but it is going to probably do some kind of reinnervation. But the innervation being done is not one-to-one. You get a lot of end organs bundled into one neuron, and then you have that one neuron projecting through the collateral sprouting, through the unmasking, through stuff like that, projecting into many areas. So you have bundled efferents and bundled afferents, and you have mixing of these signals, and you got pain, and you got all these things. So you need to provide a lot of different sensory inputs, different sensations, and combine it with different experiences, so that the brain can actually try to differentiate between all this soup of afferent input.
but
It's
also,
you can also like produce therapeutic strategies along with your patient, having him do different things with his hands.
yeah, but we can. This article also showed that sometimes we have to get another signal, like with the Pavlov's dog. When there was a bell, there was a food. Afterwards, when there was only the bell but there was no food, the dog had a saliva, more saliva production. Here also, maybe you cannot feel the hand. Maybe you have some kind of wrong feelings like dysesthesias or something else, but you can add something else like touching, but you hear the touch, you hear the scratching, you can feel the warmth, or you can puncture it with the acupuncture needle. Just make another kind of sensation. And this
even smell, don't forget about smell.
Yes, the smell.
The smell.
Mm.
Not all the fingers, but you can combine the therapy with a certain smell, so it will rewire through that smell, like visual, auditory, olfactory, any kind of input coming together will sprout new connections within the brain.
And this is the problem, because this could be scientifically proven, but when you get it out of context, it is really alternative medicine that you have to feel it better. Yes, but still, yes, that maybe because um, nowadays it's sometimes for the patients it's difficult to be very focused on what they have to do. They have to focus on renovating their hands, but they just like doing it. They doing so a lot of stuff, or so they cannot be focused on remapping on their brain, because
Yes, but that is our job. You don't have to explain
yes.
to them exactly why. Knowing the mechanism offers a benefit, but we need
Mm-hmm.
to just make that into a therapy and make that be regular at
Mm-hmm.
regular intervals for a
Mm-hmm.
designed period of time,
Mm-hmm.
and actually make sure that we have a correct diagnosis, like which fibers are remaining, which fibers are completely gone, what type of injury do we have? Like, do we
Yes.
have a compression injury? Did
Yes.
we remove the compression? Did we have intrafascicular traction? Did we have scarring? Do we need to reoperate?
Yeah.
Do we need to have another QST? Do we need to have more electrodiagnostic testing? Like, when do we do these things? We need to be alert and assess the different function of the different fibers each time, so we know where to act, why to act, and when to act.
Yes, yes, but there are some problems that we cannot assess the small fibers. So the nociceptors are now, we don't have the tool to assess it. So this is the
Yes, and
first one.
actually reading through the small needle electromyography did not actually do anything for the small motor fibers. That, like, it has almost no use to detect single fiber, or
Yeah.
so the actual way to see the C fibers is the QST. You
Yes.
cannot see unmyelinated C fibers for pain, heat, and stuff like that. You cannot see it through electrophysiological testing
No.
in our clinical setting, but you can have high suspicions for this stuff and you can test it. Okay, the QST thing, it costs a lot of money. So you can do hot. Do the same kind of hot every time if you can, like mostly. Try to do the same amount of cold.
Mm-hmm.
Like, take an item in your fridge, a metal one. It should be the same every time, or have a plastic one in the fridge and it will be a different
Yes.
temperature.
Yes. It,
Like, you can have stuff and you can do it kind of in your own way if
yes.
you don't have the money to get an
Yeah.
actual QST thing.
Yeah. Because sometimes people think that this should be QST stuff, and this is many tools of that are very standardized are very expensive, and they are not usable at a clinical practice. I can show that like there is you can measure the angles in the in your joints, the range of motions with there is like easy motion I think, or something that costs like 500 euros, 400 euros about. So that's a lot of money for just a goniometer. You can use the goniometer that is plastic, but still it's not that thing. I'm using my phone with a free app, and mainly for most of the cases it's usable. And also
Yeah,
we
for
can use.
clinical practice, many
Yes.
times it's okay to use just what you have.
Yes. The worst case scenario, you use zero. Use nothing.
Use your eyes.
Use your eyes. Yes, but no. In the worst case scenario, you are using nothing. You are not doing the testing. And this is the worst, because also with any kind of exercises, the worst number of reps is zero.
Yes,
So
but it's exactly what we said in the beginning. Like, it's many times you see peripheral nerve injury, you say, okay, come in for a electrodiagnostic study at like 21 days, and we'll tell you what type of injury you may have, and come back at 3 months, come back at 8 months, maybe go see a physical therapist and wait for, let's see what happens. Like,
yeah.
we
Let's wait.
need to
Let's
be
wait.
on top of the nerve injury and treat the peripheral nervous system in the same way we treat the central nervous system, because it has not the same, but quite uh, similar ways to reorganize
Yeah.
itself and the CNS upstream to produce better results for our patients.
Yes.
I would like now to maybe have a talk with the people watching, but I do not see a lot of engagement.
No. No. Next
Only
time,
Elena.
painful shoulder, not painful shoulder. Okay, I
We
now
could have a whole nother stream going for the. I found a huge amount of articles saying what about the injectables to
Mhm.
ameliorate symptoms or to make better regeneration of the axons. And I had some very, very nice things because that's mainly what we want to see from, if there are doctors watching, we'd
Mm,
like to hear from you and see what could we possibly talk about next time, and maybe
yeah,
uh, join us maybe next time. Let's have a talk with 3 or 5 or 6 people.
yeah. About the injectables, you know that the neuro, for the compression therapy there are some kind of there are a few studies that are showing the hydrodissection which I'm using, so that's why I'm talking about, because I learned I read those articles a lot, are showing that there is a possibility that this kind of treatment could be useful for like first or second degree of the compression injuries, and but also there is one article that the orthobiological stuff, so the regenerative medicine stuff, could be useful for the injured nerves, so the lesioned nerve, and with your here was the about the Schwann cells, that they are changing their
Phenotype.
abilities to
Yeah.
regenerate. Maybe this could facilitate also
Yeah.
to
I also saw about the regular old dexamethasone,
yeah.
corticosteroids, like in the actual acute phase, they are being studied in quite not extensively, but some studies out there showing that there is a limited uh, a limited amount of better outcome in terms of regeneration. They also used aminopyridines, like the
Hmm.
one they used for MS, like the potassium channel blocker. They used it transdermally over the nerve or into the nerve using an injection, and it actually could differentiate between the type 1 injury, type 2 injury, and offer remyelination faster. Also, use ultrasound. Use
Yeah.
ultrasound whenever you can for the nerves. Like,
Yes.
make sure there is no gap. Don't leave a person hanging with some kind of gap or some
Yes.
kind of huge contusion without
Yes.
offering
Yes.
surgical neurolysis. Like, go inside the nerve that has
Yes.
the hematoma, cut the epineurium, maybe if needed, cut the perineurium, like release and make sure that there is no scar formation inside the nerve, blocking all this regenerative process that we talked about. If there
Yes.
is scar formation there, no matter what you do, you will not get that action to regrow into
Yes.
the
Yes.
distal
Because
stump.
there is a wall that is blocking it.
Yes,
Yes.
like
But
we need to be able to see that.
this is the another time that ultrasound is useful, but you have to learn the basic stuff. You have to learn the normal anatomy. Then you can learn about the pathological structure, because ultrasound is only the structural side.
Yes,
You don't know if the nerve is growing, how it's going on, how it's functional. It's only the structure, but
yes,
still I saw a lot of nerves that structurally on the ultrasound was not very good. There was some kind of hypoechoic
appearance.
areas or
Yes,
something. There was a swelling, but there was no sign of neuropathic pain or neuropathic diseases. Also, I saw a lot of patients with carpal tunnel syndrome, with the Tinel sign, with the fallen, reverse fallen, everything, and the nerve was in the limits, and there was nothing going on there,
yeah.
and so sometimes there's the
So
double crush syndrome. You said
this means
the
you have a testing a measurement that is not actually that sensitive. So the patient reports something and
Mm-hmm.
your measures do not catch it. We see a lot of people that come in with pain and they have no changes in the nerve conduction velocity
Yes.
because large fibers are not part of it. It's
Yeah.
just the pain fibers, just the C fibers.
Yeah, but also in the like carpal tunnel syndrome, a lot of patients have the pain like in the forearm or in the
Yeah,
elbow.
referred
So
pain upwards.
yes, so yeah, yeah. It's not like when sometimes the people have the glove hand symptom that all of the fingers
Yeah,
have the
also
numbness.
the ulnar nerve, and it's
Hmm.
not the ulnar nerve maybe.
And sometimes and there is another problem because the patients sometimes don't know um, how to uh, how how to say it, how to talk about their pain. They don't know how to describe it, and they don't know how to describe what is the numbness, what is the paresthesias. They there is for them is the same, but it's
Just
not
do
for
a
us.
QST, do your own
Yes,
QST. That is my,
yes, yes. Is the anamnesia is very important, but we also should do the
atomic
testing.
history.
Should do the testing and should do it in if there is a possibility we should have a number, maybe like the Celsius degree of the cold threshold or the algometer.
You can have just water and have a microwave. Just try to have a thermometer in it. Make sure it's 40 degrees, see what it is.
Yeah,
50 degrees, see what it is. Like 30 degrees,
yeah,
0 degrees, put it in the freezer. It's not very, very hard. Like you have an appointment and it's a peripheral nerve injury. Have things on hand that you can use to assess each fiber type.
yes,
It's it's a thing we did not do before.
yes, and
I
yeah,
think we are 1 hour into this.
yes, 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 that's about. There are no, they are engaged, but not so engaged to ask questions
They are passively engaged.
passively. Yeah, no, no comment on that.
Okay, I'm hoping that they will contact us at some point
Yes,
personally
yeah.
and just try.
You see the comment?
Yeah, I see. It's a fellow physiatrist who was doing his own stream yesterday with a lot more people. So maybe we can have him over too.
Yes, yes. He will show us his handsomeness.
Yeah.
Yeah. Do you have any idea for a topic next time?
Not yet, but I think we will get at least some input.
I
Any input
I have
is
one. I have one, and I will
well,
try
yeah,
if this works. I think that injectables in the peripheral nerve injuries. This will be a follow up for
yeah,
this stream. So
it
I
will be a
think
very good one.
so. Just like maybe not just like not something different now. Just like now scoliosis or something, but maybe
Yeah.
a follow up. This would be easier for our stream followers now to follow
And
up.
we can also have a member of some other specialty maybe join us
Yes.
and have their say, either from the neurology side or from the orthopedic and hand surgery and microsurgery. Because Christopoulos Panagiotis, which you see here, is
This.
actually an orthopedic surgeon too, along with another colleague of ours. So they could join us and we could talk about the surgical and neurolytic interventions for the microsurgery and what to do when you open up a nerve. We found a lot of good articles on this, and it would be also a nice thing. So, what we can inject, what they can see during the procedure, and what we can do to aid them during and after the procedure.
Yeah.
Or maybe we can see the imaging of nerves. How do we image them? Like the MR, the ultrasound, the functional status for the electrodiagnostic studies. We have so many things we could do. 1 or 2 follow-ups, and it would be very nice.
Yeah.
Or maybe we can see the imaging of nerves. How do we
Mm.
image them? Like the MR, the ultrasound, the functional status for the electrodiagnostic studies. We have so many things. We could do 1 or 2 follow-ups, and it would be very nice.
Mm. here Julia said about the that we could do the same thing about the tendons. I think I have one guy in mind, Karol Szapel from Poland, which is, but I think I will have to. He said he will do that with me, but we will have to address the time, just like to when we will do that. But he is out of his league. He would be very good, very good base of knowledge for the tendinopathies. So yeah.
So we had a lot of people. Like we expected exactly something like that, 20 to 30 people.
No, I expected 5. So.
No, I did expect like 20 people. We had a great time.
Yeah.
I hope you had a great time too.
Yes.
And
Yes.
I hope everyone else had a great time.
Yes. But I will prepare myself better for the next time.
We will try to make it in a way that they can actually open up the mic and offer their view. But I'm hoping that they will have more constructive comments and not.
But you know that I can send the invitation for the Google Meet and they can just hop in.
If Google Meet can support that many people, then you can moderate the discussion and we can do it that way.
Yeah, I can do it because I am the moderator, I'm the host, so I can add the people. So that's no problem. I will just put the link and.
Also, I see Haris Balsamidis saying that his English speaking is not there yet. We will aid you through the process. We need to get people out there and we need to really speak up internationally, probably.
Yeah. Thank you very much. I will end the transmission now.
Thanks to everyone that came and watched. And Marcin, thank you so much. And we will be in touch as we do every week.
Yes.
Have a great night, everyone.
Have a great night.